Welcome back, and you're watching A Bold Differently. In this second part, we talk more on cause, management, and support for families and individuals with sickle cell disease. Take a look.
From the experience I have had, wale madaktari wa zamani, wale sasa rika yenyu ilikuwa naenda clinics na hospitali, hawakujua so much about sickle cell. So hao madaktari walikuwa na base tu kwa, walikuwa wanachora, mimi sijui hiyo vitu ya sijui. SS sijui nini wanasema sasa hii chances huyu atakuwa nayo, huyu hatakuwa nayo.
Sickle cell is a genetically blood disorder, inherited blood disorder, which is characterized with body pains. You get most of the time children are complaining of body pains, delayed milestones. Sometimes they have low blood levels.
One has to undergo a series of tests for diagnosis to be made.
We have the sickling test, which can be done anywhere. So long as you have the microscope, you have a lab technologist, that is all you need. Sickling test is non-specific, so it is not really, you will not use it as a standard test to make a diagnosis for sickle cell. However, in a low resource centers, then it is still used as a first line diagnosis for sickle cell. Then you need to come, we have the second test, which is a sickle scan. However, it is not really widely used. Sickle scan is just like a rapid test that you can do just on the bedside of the patient or on your consultation room or even in the laboratory, and you get your results in a straight 15 minutes. So it works almost like HB electrophoresis. However, it doesn't quantify for you in terms of what is my percentage in terms of the disease progression. Then we have the HB electrophoresis. The HB electrophoresis is the gold standard investigation or the confirmatory test for the sickle cell. So the HB electrophoresis has got three functions, very important functions for us in the clinic. One, it is used for the diagnosis. Remember, we have suspected a patient probably having the signs and symptoms. We have done the sickling test. Then now we come and do the HB electrophoresis as a confirmatory test. So it will be able to give me in terms of, now it will give me the different traits of sickle cell. Am I a sickle cell trait? Am I a normal patient, or am I true sickle cell disease?
As in the case of the three brothers, people with sickle cell disease can develop other complications.
Any part that has got blood supply, then expect side effect or complications to arise. So all the way from the top, from your head, all to the toes. So it depends. Not all of them will exhibit the same symptoms or the same complications. So the complications will arise as the way a child is being treated, the adherence to the clinic, and also the well-being, the way the child is being brought up. For example, the case of Kevin Baraza having an infection of the hip, or probably having we call it a vascular necrosis of the hip. So in this case, then it means that we have overall impact on blood levels within the system of your body, whereby the hip has got, it's a large joint. It's a very huge joint that needs a lot of blood supply. So when you have a very low level of blood, then it means that even the oxygen which is being carried in that blood has to go down. So for the survival of this hip, it needs a lot of oxygen, a lot of blood. So when the sicklers, they have reduction in terms of blood levels, then it means that hip will have to undergo certain something called necrosis. Necrosis is just a cell death. It's a normal cell death that can occur because of other factors, but for the sickle cell, then it will be because of the low blood levels. For Ian, it's not really so much. It's not a very much impact in terms of stroke level, but he got something we call an impending stroke. An impending stroke is not a full stroke as per se. It was arrested before it became fully, whereby the certain part of the limb that was slightly weak, we were able to resolve it through we were able to increase the capacity of hydroxyurea that he was taking, and also with serial episodes of physiotherapy, then he was able to recover a certain part of that part of the limb. However, it's not fully recovered, but at least compared to the way he was before, you have seen a lot of improvement.
As Dr. Moses Apela explains, both parents are responsible in a sickle cell case.
For us to get a child with sickle cell, then it means that both of the parents will be having almost the same trait. So trait means that one side of genetical makeup has got sickle cell gene and the other part is normal. So when these two individuals come together and get married, there is a percentage of probability that they can able to get a child with sickle cell, and there is also possibility that they can have a child who is completely normal, and then there is also possibility that they can have a child who is having a trait. So in terms of percentage, if we go straight to the percentage, then for them, the probability of getting a child with sickle cell will be around 25%. And also giving birth to a child who is a trait, it's around also 25%. And normal, which is normal, it's 25% also. So if you do a total of these, a normal child and a trait child, if you look at them on a physical appearance, then it's not possible for you to differentiate them. So then the probability of these parents giving birth to normal children is about 75%. And it's only 25% they be able to get a sickle cell child. So this 25% is not specific that the first pregnancy will be a sickle cell child, then maybe the next one. So it can be, the entire family can be 25% of sickle cell. Or sometimes you get the entire family can be normal, however they are traits.
However, the myths make it hard for families with sickle cell patients.
We tend to demystify some of those things that we are told. People are told that if you have sickle cell, you will die young. That's not true. Today we have interventions that have proven that people can live to old age. The only thing we need is strong support groups. Children's Sickle Cell Foundation is a support group, but also we work with institutions that help our members to get help, clinical care, and also just education about sickle cell. The foundation was founded in 2001, and then there were more children. We were not seeing many adults, and when they started the organization, the concern was on children. But these children have since grown. Some are today married people with families. So instead of changing the name, we still thought it's good to retain it. But then we start from children because the focus is on the child.
With the need for awareness, there has to be a wider reach.
In 2001, we had an opportunity to work with the sub-counties within Nairobi, targeting Kibra, Kangemi, Kawangware, and Mathare area. What were we targeting? We were looking for patients with sickle cell. Then we expanded this. So in 2022, our mission is to reach Kisumu and Mombasa, where we are working with the governments. Now, what are we doing? We are trying to talk to these two governments to create structures where when patients go to these facilities, they are able to access care. We are now talking to the county governments. How do we strengthen the CHV's ability to create awareness? How do we strengthen the healthcare workers' situation in terms of lobbying?
COVID-19 halted some of their planned activities.
In 2019, just before Corona, we went to a school in Kariobangi, and we managed to have a session with 1,500 pupils. That was class 5, 6, 7, and 8. As we were trying to expand to this, Corona came in. So because of Corona, we've been limited towards movement in spaces like schools. So this is a good place where now we can go back to the county government and say, now we want to go to this school, we want to go to the other schools, and see how we can create awareness on with the pupils and the students. Workplace also, because we've realized that the caregivers are working, but sometimes they have to take time off to take care of their children. The employers don't understand sometimes. Some even feel that, oh, we are pending to kufanya kazi kila saa nasema mtoto ni mgonjwa. But sickle cell is that sporadic. 1 minute the child is fine, the next thing ameamka asikii vizuri, hautasema mimi naenda kazi, wewe jipange.
Of the three brothers, Selina says that they will need all the support they can get.
I met the family many years back. I think it's more than 10 years. And I met when Kevin was still a young boy in high school. And Ian was also in school. And also the small brother Joshua was actually a very small boy. And this was a special case to me, because Kevin is a young man who had a promising future. The only problem he developed later was he had a hip problem. As for Ian, he's always been a stable young man, and people who you love to interact with. They are intelligent boys. The young brother just developed, nowadays he's having problems with anemia, many transfusions, which I think it's something that we need to sort out, this problem. Now, the one issue that comes to me every time when I ask myself, in this country, if a parent or if a couple gets more than one child with sickle cell, who then do they run to?
There is no known treatment for sickle cell. However, bone marrow transplant is still on trial.
On the bone marrow transplant, it has never been done in Kenya. We have had patients who are maybe a bit able to afford. They travel all the way to India to be done a transplant.
Selina advocates for a package for sickle cell patients.
If we had a package, which when you're born and we know you have sickle cell, this is the estimation, that's fine. Now today these boys have complications. Now these complications demand more. So today I cannot estimate that Kevin requires X amount monthly. But on a rough estimate, Kevin needs his daily medications, which goes to about between 4,000 to 6,000 a month. Now, besides his daily medication, he also needs medication for pain, and he's not now using the regular pain medication. Sometimes he has to go to very strong medications. There's also infection that comes in once in a while. So, in a rough estimate, I really don't know how I would quantify that, but this is a family who, I would say, for just one child, must have reservedly 50,000 per month for one person. Because when this month is running, they could easily spend that 50K. But that is on a lower side. In a setup like that one, these are people who have individual problems. We may say, oh, our problem is sickle cell. That's the common denominator. But when you now go into depth with each and every person in the household, you find that that kind of family really requires a lot of mental health care. And that's what now we do the much we can, but we know very well we've not even reached a quarter of what they need.
Let's take a look at the UN Convention on the Rights of Persons with Disabilities.
Article 25 of the UN Convention on the Rights of Persons with Disabilities states that state parties shall, Part B, provide those health services needed by persons with disabilities, specifically because of their disabilities, including early identification and intervention as appropriate, and services designed to minimize and prevent further disabilities, including among children and older persons.
And here is the tip for the day.
The predominant areas that are so much prevalence with the sickle cell, then the statistics shows us that it's more on the lake region and where there is large water bodies. And the large water bodies, we are talking about the coastal region and the lake region. However, with intermarriages, it's now coming out like it's not more about the lake region.
We say goodbye for now. However, let's keep spreading this awareness, and we call on everyone's support to make the lives of people with sickle cell much easier. My name is Jane Theuri.
I'm Ruth Mweni.
Goodbye.
We are here and we are strong. Let's be counted as we move on. Make a difference, change lives as we tell our different stories. We are capable, beautiful. We are born to do great things. We're unstoppable. incredible, 'cause we're differently abled, differently.